ثانك يو. السلام عليكم، صباح الخير، مساء الخير. كل الشرف ليا لحضور مؤتمر عظيم قصر العيني، ودايما انا حريص ان انا احضره. قبل ما ابدا دايما انا بقول في وجود الدكتور شريف عبد الفتاح الدنيا بتختلف خالص. اتعلمنا منه وما زلنا، ففي وجود الدكتور شريف كلنا تلامذه مش اساتذه. فكل التحيه طبعا للدكتور شريف علشان وجوده بيسري دايما اي جلسه. شكرا دكتور جمال عصمت على الكلام الجميل، ويعني انا بعتبرك الفيجر اللي لا ينسى ابدا لافضالك. دكتور مازن نجا طبعا العظيم اللي دايما بنعتبره سواء في جامعات مصر كلها هو الايقونه، فدايما وجوده بشرف لنا كبير. دكتور علي فرج، الدكتور ايمن فؤاد، الدكتور محمود وهبه، ارجو ان البرزنتيشن تنال يعني قسط وافر من الرضا عنها. لكن هو دايما الكلام بعد الدكتور شريف مجاور بيبقى اكيد صعب because he is very intelligent in preparation, and I hope I can make a good presentation like Dr. Sharif. Now, what about the approach to treatment failure in inflammation? What is treatment failure? This is very important. If you follow this research about following 100 patients with IBD in such a new research published in the year 2022, they were following 100 IBD patients, and they found that 50 to 60% had initial response. And from these 50 to 60%, only 20 to 30 patients had remission. And from these patients having remission, only 50% remain in remission. That's to say, only 10 patients out of 100 patients remain the remission. It's very low incidence of cure. So, how can we put failure according to these results? Is failure just failure to gain initial response or to maintain and had remission? I think the answer is very clear. No initial response is primary failure, and having no remission or maintenance of remission is secondary failure. So, according to the definition of treatment failure, adequate exposure to the drug at the correct dose, that means at least 2 weeks during the induction phase, with exceptions are anti-integrin agents which may take a little longer, perhaps 10 to 20 to 12 weeks. But we have to make more assessment about treatment failure. So this is primary failure, failure to gain the initial response. And most of the initial responses needs about 3 months by giving the medication to the patient. And this is secondary loss of response. After gaining the initial response, they cannot maintain that response. Sometimes there is failure due to development of side effects, both true and perceived. Also, maybe your patient had good symptomatic response, but after doing endoscopy, we failed to find good mucosal healing. If we didn't get this target, it's some sort of failure, and we have to revise our medications again. Even lack of symptomatic resolution with or without mucosal healing is failure. Also, the inadequate drug exposure due to a host of reasons, including inability to pay and poor adherence, is some sort of failure. Now, what is the next step in a patient showing non-response to infliximab? We are giving a patient infliximab. So what is the next step if the patient didn't give a good response? Should we increase the dose of infliximab? Should we replace within the same class? Should we change the class? If you asked me this question 2 decades before, I can tell you that all the answers are right. Yes, 2 decades before, I increased the dose to see whether the patient will give a response or not. I can replace with the same class or change the class. I mean that 2 decades before we were blind and all the answers were right. If you asked me this question now, currently, I'll say that no, this question is missing something and we should complete the question in a more reasonable way. If you ask me this question now, I'll tell you, no, I should make this therapeutic drug monitoring and antibody titer for the patients in order to answer your questions. So please revise your question again in order to make a good answer. Let the question to be like that. What's the next step in a patient showing non-response to infliximab? But you have to add who has adequate drug trough level and no antibodies to infliximab. Can you guess? If your guessing is right, please follow up. Follow with me the coming slides in order to know whether your guessing is right or not. هل يا ترى اللي بنديله انفليكسماب ده وما اداش ريسبونس وعنده جود تراف ليفل وما فيش انتي بوديز ننكريز الدوز ولا نريبليس ولا نشينج كلاس؟ فولو. Now to make it more challenging, I'll give you another case. Try to concentrate on this case. This is 26 years patient with Crohn's disease on adalimumab 40 milligrams since 3 months, suffering from occasional loose stools with frequent lower abdominal pain since 4 weeks that relieved with defecation with some urgency postprandial. Investigations shows normal abdominal sonar and stool calprotectin in addition to CBC and CRP. Can you get the point? Our patient having medications, but he has diarrhea and so and so and so. Now, what are the choices? How to manage such a patient? Ask for lower endoscopy, make more investigations, change medications, add steroids, follow up with diet control and antispasmodic. What do you think, our chairpersons? What do you think?
You have to confirm why he has this diarrhea. It could be due to the inflammatory bowel, and more likely it's not due to the inflammatory bowel, it could be something else. He could have, as an example, IBS, and he is well controlled on your medications.
So can you diagnose inflammatory bowel with normal stool, with normal calprotectin, with normal CRP? And the type of the stools and the surroundings can give you any hint? Any suggestions?
He has abdominal pain. It could be to something else, like strictures, like something else.
Yes. Again, this patient have loose stools. Yes, please.
We should think of superinfection, actually, such as cytomegalovirus or maybe Clostridium difficile. This is quite common with the medications that we use. We have to rule out. Also, we should rule out intolerance to certain foods, such as lactose, which is very common in inflammatory bowel disease.
Okay, but let me to revise it again. This patient have loose stools with frequent lower abdominal pain since 4 weeks that relieved with defecation with some urgency postprandial, and all the investigations are normal. Is this may through some shadow about Rome criteria? Yes? Yes or no? Is it possible to have IBS with IBD? Yes. More than 26% of Crohn's patients having IBS. And in my opinion, what do you think, Dr. Sharif?
I totally agree من السيمتومز دي حضرتك انها functional disorder وماشيه مع الروم كرايتيريا، فتخلينا نروح للاي بي اس اكتر. والتشويس بتاعي في الحته دي هيبقى فولو اب ودايت كنترول وانتي سبازموديك، خاصه ان العيان بياخد التريتمنت وكل الكرايتيريا كالبروتكتين وكومبليت بلاد بيكتشر وسيرا اكتيف بروتين didn't denote anything تدل على activity of IBD.
Thank you, Dr. Sharif. You sent my message already. You can diagnose IBS in a patient with IBD if you find all the investigations are normal with something throwing some shadow about room criteria for IBS. Now, is there any predictors to predict that your patient will fail in therapy? Actually, there is no single biomarker that can predict treatment response, and several markers are available, particularly for anti-TNF agents that may predict treatment failure. If you find deep ulcers, high CRP, low serum albumin, and patients with high inflammatory burden, this may indicate that your patient may fail in therapy. Now, dose optimization is the key factor to have the best response with biological age. You have to measure therapy, biological therapy. Once you are following your patient, and the concentration of biological agent or therapeutic drug monitoring is very important on following your patients. If you find that your patient have low drug or optimum drug concentration, if he has optimum drug concentration with failure of medication, this is called mechanistic failure or primary non-response. If you having a patient with failure for medications with low drug concentration, this is called immune mediated if you find anti-drug antibodies. If you find failure for medication with low drug concentration and without antibodies at all, you can think of what's called non-immune mediated mechanism, like sometimes 6 in male patients, body mass index, albumin, low albumin level, severity of inflammation burden, or no drug antibodies. In such a case, you can adjust the dose or change the interval. This is the only choice to increase the dose or to change the interval in order to get a good response. When and how to do this art of therapeutic drug monitoring, whether it's reactive or proactive, I think this is still that time is debatable. But the standard of care is to ask for reactive therapeutic drug monitoring if your patient is failing medication. Now, in order to summarize, how to approach to determine drug failure in IBD, you have to check first the symptoms of the patient. Verify that the symptoms are due to active mucosal disease by CRP and fecal protectin with imaging and endoscopy. So if you find or you didn't find inflammation present with failure of medication, you have to think about the development of complications that is underlying failure for this patient, like strictures or fistula. Or the patient may have overlying conditions as our case, IBS, SIBO, or bile salt diarrhea with enteric infections. In such a case, diagnose alternative cause for symptoms and treat accordingly. If you find inflammation present, verify drug adherence, total duration of the drug exposure, and check drug concentration and antibodies. If you find low drug concentration with high antibodies, switch to alternative biological agents in same or different class with concomitant immunomodulator. If you find adequate drug with no antibodies, switch out of class. If you find low drug level with no antibodies, as my case, the first case I told you about, escalate dose and or add immunomodulator. By the way, if you give your patient infliximab and he didn't give a response from the very beginning, this is primary response. What you should have to take for the second step, For patients with primary response, you have to shift out of the class. Don't give the patient any medications from the same class if you have primary drug failure. So don't give Humira, for example, after infliximab if you have primary drug failure. If you have secondary drug failure with development of antibodies for infliximab, you can give for even the same class like adalimumab or so. Now, we have two steps to think about and to take it obligatory. Distinguish active disease. This is first step. The patient have what refers to activity of the disease or inflammation versus non-inflammatory symptoms. Then, after you deciding whether the patient having this inflammation or not, distinguish drug failure from lack of optimized dose. Don't change the medication except after be sure 100% that the medication you are giving is not effective for the patient and not effective as a class. Now, how successful is response to second or third line therapies? I think Dr. Sharif Megawer answered this question perfectly. And over 2 years, the response is less or about 40% if you add second or third line therapy after failure of the medications. Response or remission rates with different mechanism of action following therapeutic failure. I'll give you another question. Anti-TNF therapy failure, which is better as second drug therapy? I think Dr. Sharif answered also this question. In such a case, you will give anti-interleukin or anti-integrin or JAK inhibitor. What do you think? Any suggestions from our chairpersons?
If your anti-TNF is failing, your second choice, if it is ulcerative colitis, JAK inhibitors or anti-integrin. But it's never the VIDO. If it's Crohn's disease, stickimumab is okay, and the new drugs are very well working with this, the UBA and the RIZA.
Okay, I think we have a lot of circumstances that can change our opinion about how to choose from these medications. It depends on whether the patient having any complication like fistula or stricture, or the patient is having extra intestinal complications, the age of the patient, any associated diseases, and about his immunity responses. But actually, in a study, all have similar efficacy. This is my opinion. I don't know whether Dr. Sharif will comment about that or not, but Dr. Sharif telling us about the details of positioning of medication, and he insisted about safety, patient preferences, and the mode of administration. We cannot terminate our speech without going through the surgical therapy after failure of conventional therapy. 15% of patients will still require surgery early in the course of their disease, often because of complications or refractory disease. My message, the two rules recommendation is very famous. The first rule, drugs should only be deemed failure after they have been given enough time to work at therapeutic drug concentration with confirmation that inflammation is present despite drug optimization. The second rule is not less important. Don't forget the first rule. I can't finish my talk without speaking about Professor Dr. Isma Chiba, and this presentation is dedicated for his memory. He's a great professor, and I cannot finish my presentation without blessing him. Thank you very much.